What may be what may be an unprecedented event at an academic conference, we are starting on time, so give yourselves a round of applause. Well done. For those of you who haven't formally met, I'm Matt Harris. It's nice to meet you, and welcome to the 14th edition of the annual Health Econometrics Workshop. A couple of things just to get us started, and all of it really gratitude. So first off, I want to say a thank you to our sponsors, AHRQ, which a lot of this conference is funded through an R13 grant. I want to say a big thank you to our hosts. To get a round of applause for USC, please. With Enrique, you want to raise a hand? So we are also sponsored by State Corporation this year, and so special thanks to Enrique and State. I don't think we have any representatives from Pfizer here. We're grateful for their representation in this conference too. And last but not least, my employer, the Boyd Center for Business and Economic Research, is picking up some of the food bills. So thank you very much to Don Bruce and the Boyd Center. I want to say a quick, just if you would, just stick a hand up in the air. John Romley, our local chair. Thank you. So Anirban Basu, Partha Deb, Austin Dente, Monica Garcia Perez, Melissa Garrido, Edward Norton, Nick Papa George, and 4 members of the community that are not here, Donna, Audrey, Paul, and John Malahy. I want to thank them for their work. And finally, just a massive, massive thank you for 2 people who have just deadlifted the logistics of this conference. So Gladys, round of applause for Gladys. Erin Hatfield, who's, if you guys give Erin a round of applause, she's outside. Run the audio on headphones and record this. All right, last bit from me, and then I'll turn it over. So our oh, come on. There we are. So our discussants for the first session are going to be Kathleen Mullen from Oregon and Emily Cuddy from Duke. Okay. And the authors for our first session will be Vicki Barone from Notre Dame and Shengmao Cao from Northwestern. So, all right. So great for this debate. You guys are here, and we'll introduce the authors kind of as we go along. And in the meantime, I want to turn it over to John to say a couple things.
A couple more thank yous. Sorry, but I'll be quick. Thanks to Matt and the committee for the opportunity to host. I want to thank my Vice Dean for Research, Alice Chen, for the Price School support. Matt already thanked Aaron and Gladys, who've just been wonderful. I would also thank Daniel George in the back for IT. Thank you.
Thanks. I will not add to the thank yous, but thank you, to the conference organizers, and especially for John and Gladys and Aaron and Matt for all of their work. I just want to welcome you to USC Price and welcome you to this conference. It's a fantastic conference. It's one of those unique conferences that brings together faculty and grad students in an almost seamless way, and has the discussants reading the author's papers and making sure it makes sense, or some sense, hopefully. And I look forward to learning with all of you in the next 2 days. Thanks.
Thank you, Alice. Thank you for having us. All right, so our format for today will be, or format for the next day and a half actually, will be discussants. You get about 30 to 35 minutes, and we'll have a timekeeper, which for the first bit of the day is me. Authors, you didn't have 5 to 10 minutes to respond, hopefully constructively, to the discussants' constructive comments. And then we've got the balance of the time allocated for that session for Q&A, and hope everybody keeps that conversation going in the hallways. So with that said, Kathleen, if you would, please come present.
Am I supposed to use this?
You can also yell too.
The people on WhatsApp? All right. Okay. All right. Hi, everyone. Thank you so much for the opportunity to be here today. This is my first time participating in this conference, and the first time participating in this format where the discussant presents someone else's paper. So it's kind of an interesting exercise for me. I actually teach a class on labor, a grad seminar on labor and social insurance, where part of the class has my students presenting other people's papers. So this is, I guess, a great opportunity for me to walk a mile in their shoes and kind of see how that works. So I'm going to be talking today about the design of paid sick leave, taking a structural approach, and the paper is by Barone, who is right here. So this is annoying because this little guy is in the way. Okay, all right. So as a public economist, public and labor economist who studies social insurance programs, my first kind of way of thinking about these types of problems is, what's sort of the problem here that paid sick leave is intended to solve? So, when we're thinking here, we're going to be thinking about it in the context of a social insurance program, which is meant to transfer resources to people across different states of nature. So this isn't, we're not thinking about transfers, across different types of people. We're talking about, transfers to people in different states of the world. So, and as with any social insurance program, we want to balance the value of that insurance, to someone like me, a risk-averse individual, against the effects of moral hazard, where maybe in this case I take more sick leave, or I stay away from work longer than I would have in the absence of sick leave, or depending on the design of the sick leave program, it might, kind of encourage me to stay away. So here are the states that we're thinking about are, a healthy person going to work and getting their 100%, full productivity, against, someone who comes down with a short-term illness that impairs their ability to work potentially, but does have an expected recovery in the short term. So, I'm very familiar with the context of disability insurance, and there's a very large, literature on that. But, in disability, we tend to think about where, suddenly somebody is unable to work at all. And, how do we kind of, insure against that risk? But here we're thinking about the risk of being temporarily unable to work because of a health problem. So, in the literature, this is referred to as absenteeism. So we're, kind of thinking about people who don't go to work. Or if they do choose to work while they're sick, then they, may have reduced productivity. So we have to take into account the cost of presenteeism as well. So they're, they may choose to work a little bit at their full wage, but they aren't, getting their full marginal product. An added concern with presenteeism in this context is that if you have infectious diseases, then you could, going to work, you could be spreading your illness to your fellow workers, and that could mean that, more of your other workers are, sorry, the way that this is set up means I'm spending a lot of time looking over here, ignoring you guys, and it feels very weird. I'm very sorry about that. So if you're spreading your infectious disease to your fellow workers, then you could be impairing their productivity and causing a bunch of them to, stay out of work as well. So in this case, encouraging people to stay home when they're sick, could have this added benefit because there's this externality that they impose on their fellow workers. And potentially their customers, right, if they're public-facing jobs. So I'm going to do the sort of classic discuss it thing where you reference your own work, partly because I was, too lazy to, change these slides from my intro slides in my grad class. But there's a lot of evidence, or there is evidence, that workers value paid time off a lot, at least in the US. So a recent paper by me and some co-authors used an experimental research design to try to figure out how workers value different job amenities or workplace conditions. And one of the things that we varied was the availability of paid time off. So we looked at job offers with 0 days of paid time off, 10 days of paid time off, and 20 days of paid time off. And in that setting, paid time off was the strongest predictor of job choice. It beat out physical demands, pace of work, autonomy, a whole host of different things. And, we found that workers really valued the paid time off sort of over and above the, reduction in labor supply that would be, associated with taking the same number of days, off, assuming they've got, some vacation days in the year. So, so there is also this component when you're thinking about a system with, no paid time off to paid time off, of job protection, I think that is probably, built into numbers like these. So, we want to be thinking about that element as well, that, paid time off is also sort of protecting workers who choose to stay home while they're sick from, not getting fired from their jobs. So without a mandate, it turns out many firms don't offer their workers paid sick leave on their own. And so many countries provide paid sick leave, either through an employer mandate, where they mandate employers, provide some kind of minimum level of sick leave, or through social insurance programs like, sickness insurance. So the pandemic kind of inspired this really interesting report called Contagion Nation back in March of 2020, where the Center for Economic and Policy Research followed up on a 2009 report where they looked at, just a comparison of paid sick leave policies in several high economic and development countries. And, their headline was the US is the only wealthy nation without paid sick leave. So many of us work in the US and have that as our kind of background, for what we're thinking about here. So, the way that we think about paid sick leave in the US is usually you get kind of 10 days a year to use cumulatively across all the different, potential sicknesses that you have, or you get 20 days a year. You kind of determine on your own, whether you're sick and how to take those days. But a lot of different countries, have social insurance programs like the context that we're looking here today in Chile, or they have employer mandates that, are kind of spell-based. So you can see that, here you've got a mix of countries that E stands for, employer-sponsored sick leave, and SI stands for sickness insurance. So there's a lot of variation in how different countries approach this problem. And then this is just the end of that, table from that report, where I always go, look at US, it's got none on all these things, how sad. But one thing to look at here, if you can kind of, take it all in at once, is that a lot of these programs share certain features, like they have a waiting period, something like 3 days where you don't get, any reimbursement for the time away, and you might not get full replacement. So, we can maybe draw in some of these tools that we look at, in other social insurance programs like unemployment insurance and disability insurance where we have imperfect replacement rates. Okay, so let's talk about this paper. So what does this paper do? So it proposes a sick leave provision where we have risk-averse workers facing health shocks, and then they decide, based on those health shocks, how many days to be on leave, in the context of the, benefits that they face. And then there's a risk-neutral social planner that chooses the optimal contract to maximize social welfare, given the worker's behavior. So the social planner says, okay, I can kind of do this benefit schedule and see how workers, might respond, and kind of look at all the different benefit schedules and find kind of the optimal one. It's definitely like a new, so one thing that was very funny to me when I started preparing for my class, adding sickness insurance, was that basically there's not a lot of research here. So there's a ton of stuff on workers' compensation, disability insurance, unemployment insurance, but when I got to sick leave, I was kind of like, oh, what do I do? And so, there is a paper by McLean, Pichler, and Zebar that tries to focus on optimality conditions for looking at an employer mandate in the US context. So this isn't the first paper, to try to, look at optimal disability insurance. But here we're focusing on a context that, it shares features that are similar to many other countries and isn't really looking at an outlier, but, something that looks very similar to what we see across other countries. So I'm probably going to swap out the McLean paper with this paper when I teach my next social insurance class, and we'll kind of walk through that. And so I'm definitely curious to see, when this thing gets published and kind of what it looks like, and follow the process of the paper, and then what papers it generates as well. So we estimate a structural model using a unique administrative data set from Chile on sick leave utilization or not among eligible workers. So one really nice feature of this data set is that it's not, only spells of sickness insurance. We can also observe some zeros here, people who, don't ever, take sick leave, and build that in. And one thing that I really like about this paper is it combines, this data set with innovative data on estimated recovery times from this outside source, the Peruvian Handbook of Recovery Time. So it's a different country, and it's not, kind of influenced at all by the structural setup of the Chilean system. And, this handbook basically takes a bunch of different, illnesses, using their ICD-10 codes, and estimates recovery times by age, gender, and occupation. So my impression here is that occupation is just blue collar versus white collar job. It's not like, administrative assistant versus, truck driver, that level of granularity. But it basically says, okay, this person is maybe a little bit older, and so this, flu spell, might take longer for them to recover, and so it kind of builds that in. In reality, when we observe people taking days off for the flu, we have to worry about them making that choice, right? Based on the prevailing social insurance system. So this is a really nice kind of add-on to the paper here. And then, so we're gonna estimate this model, and then we're gonna apply these model estimates. And then we're gonna try to basically, solve this problem of what's the, optimal kind of benefit schedule within a class of benefit schedules. And so we're kind of focusing basically on the replacement rate at different levels of sick leave in this case. So, trying to boil down the features of the Chilean setting for like things that we need to know to be able to understand this paper, right? So paid sick leave is administered in Chile by health insurance providers. And workers are mandated to purchase health insurance. They have to set aside, I think it's 7% of their earnings to buy, health insurance. And they face a choice of plans, but they do have a public option. And 73% of workers in Chile choose that public option. And then the rest kind of choose between a handful of different, private insurers. Insurers have to follow the sick pay schedule that's set by the government. But in practice, there are differences in how they administer the program. So Vicky shows that private insurers are 3 times more likely to reject sick pay claims than the government health insurance provider. So that's, they're rejecting like 15% of claims that come in versus 5% of claims that come in. And that motivates the choice of using, focusing on workers who choose the public health insurance option, in this paper. So what we're thinking about is a group of people who they had no choice in the benefit schedule. They couldn't select into, different options with different benefit schedules. You might worry a little bit that people who chose the public option do value sick leave more because they know that they're less likely to be rejected. And so there might be a little bit of selection in, but not, I don't think it's necessarily a big concern. So in terms of eligibility criteria for sick pay, workers who've been enrolled in Social Security system for 6 months and who've made health insurance contributions for 3 months are eligible. That is what it is. So this is an interesting feature from my perspective. To call in sick, a worker has to obtain a physician's certification of their sickness, stating a primary diagnosis and the estimated number of days needed to recover. So this isn't something where I'm feeling like really out of it and I just decide to stay home. Like I'm feeling really out of it. I don't want to go to work. And so I have to go to the trouble of, obtaining that physician certification, saying that no, she really can't work. So I have to admit, it's kind of amazing to me that anybody could do this at such a short, time period. When I try to make a doctor's appointment or get in touch with my doctor, even just through email, I have to wait like a couple of days, right? So administering a system like this really does seem to rely on, very fast response times from physicians. And so you could see also how someone on the margin of taking the day off versus not taking the day off just decides, oh, forget this. I'm just gonna go to work anyway and kind of work at, half strength and, deal with it because it's only, a day or 2 that I'm anticipating, taking off. So I do think some of those zeros are probably, like 1s or 2s in some sort of reality. But, for the most part, like the integration of the physician, certification, what that really buys us is like amazing data. So we should all be, very, I think, happy about that, just as applied economists. So Chile, like many other programs that I showed you, has a 3-day, waiting period. I believe this is per spell. So if I get, COVID like twice in a year, then, the first 3 days off of each spell are unpaid. And then there's 100% replacement rate for the next, days 4 through 10. And then this is a really interesting feature that for spells lasting at least 11 days, then the worker is basically reimbursed for their lost wages during that waiting period. So they suddenly, recoup their losses, and this generates this really nice externality that, basically generates the variation that we can use to estimate the model here. So I would also like to say one thing that I really like about your paper is the focus on figures and showing things visually. I'm a very visual learner, and so it just like, great job. Okay, so I think this is figure 2. I skipped figure 1 because we're focusing on econometrics and I have 30 minutes. And basically the x-axis, if you look on the left side, the x-axis shows the number of days that you could potentially take for your leave. And then the y-axis shows the number of days that are paid out depending on the number of days that you take on leave. So you can see here, basically you get nothing for the first 3 days. Then you get, now you're at a 45-degree line for days 4 through 10. And then suddenly at day 11, you are reimbursed, you're back at full insurance. The full insurance line is if you had gotten reimbursed, fully since the start of your spell. And then the right panel translates this into an average replacement rate as a function of the number of days that you take off. So if you take off 3 days or less, you're out of luck, you get nothing. But as soon as you take that 4th day, now we're kind of taking 1 day and we're dividing it by 4, and so we're getting 25%, and then kind of getting more and more, and then at 11 you suddenly are back up to 100%. So you can see the nice, like there's 2 discontinuities here, one at 3 days and one at 11 days. So the data that we're using in this paper, so the main data comes from an administrative data set on sick leave claims matched to enrollment data for workers insured by the government health insurance provider. And the paper says covering years 2015 to 2019, and here's where if I had done this earlier, I could have clarified with Vicki, because it looks like a lot of stuff later is focused just on 2017. So I'm gonna let her maybe clarify that, but honestly, it's not super important for us, to know the exact, the exact years, but it's either 2017 or this 4-year period. The enrollment data includes sex, age, annual earnings, indicators for certain chronic conditions like diabetes and, chronic pulmonary disease or something like that, where the person lives in terms of the postal code and the health insurance plan that they pick, within the provider. So the provider offers multiple plans, and we're going to get rid of people in the lowest tier plan because apparently they are not active labor market participants. I believe you. Okay, so the claim data include the start and the end dates of each spell, the prescribed days on leave. So this is where the doctor, the physician says, this person is allowed to take, 5 days off. The primary diagnosis that we're gonna code using ICD-10 codes, identifiers for the physicians, the amount received in sick pay, which I assume is just kind of verifying, what we already know about the benefit schedule, and the person's current occupation. And then we're gonna combine that with estimated recovery times for a whole host of unique disease codes at the 4-digit level of the ICD-10 classification. And these estimated recovery times are given by sex, age, and occupation, where that's blue versus white collar workers. So we can basically see that, people with different kind of demographic and job characteristics can have different projected recovery times for certain, illnesses. So here we are for sure taking the ICD-10 codes as like gold truth. And so, I don't think there's any way to deal with the potential for upcoding, like convincing your physician that, really this is some more serious condition than, we have to actually observe. Maybe kind of trying to look at things in broader categories could help with something like that, but, I imagine that's potentially an issue. So I'm gonna walk through the sample inclusion criteria. We already talked about, we're looking at people enrolled in a healthcare plan that isn't the lowest tier plan administered by the government provider. We're gonna focus on private sector male workers ages 25 to 64. So this is something I try to laser focus on. Why are we looking only at male workers? This day and age, I think we really do need to justify, those choices. So the discussion here is that women's labor force participation rate is, 20 percentage points lower than the labor force participation rate among men, about half versus 70%. So, you would need to, this should be in quotes, you would need to model labor market participation decision, if you were to include them. I don't think that's necessarily the case. It's not like the male labor force participation rate is at 100%. And, I don't think that's necessarily true. I did check, and the early retirement age is 65 for men in Chile and 60 for women. So there are some differences in their, outside option for working at certain ages. But maybe a separate paper even focused on, experiences of women could be particularly important. Sick leave isn't available for caregiving in Chile, but, it could still be a margin that people kind of use. Women who care for sick children could get sick themselves, and so they could have higher, rates of getting sick. There could be a lot of interesting, features here, and so, let's just all be aware that we're looking at male workers only here. We're going to focus on non-mental health claims. The reasoning here is that these claims face additional hurdles in filing. So in addition to being certified now by a psychiatrist, you have to have this comprehensive medical assessment at filing. I think that's fine. 10 minutes, no worries. And then we're going to exclude a bunch of claims that have codes that are hard to, assign. So our final sample in the end, I think, is about 1.9 million workers, and about 17% of them, have any claim in a given year for one of these included conditions. So this looks to me to be comparable to what you see in other data sets. So I'm just going to show some really, pretty pixtures, kind of like visualizing what's going on with the data here. I think they're like fantastic. So the graph here shows on the x-axis so this is the distribution of sick leave claim duration for a number of days, and so the percentage of claims is on the y-axis, and then it's imposed over that average replacement rate schedule. So, you could be looking here to see like, oh, maybe there are a lot fewer claims at 3 days and a bunch at 4 days. That's what I would expect. And, maybe a lot fewer at 10 days and a big jump at 11 days. And I don't know that we necessarily kind of see something like that, popping out from this data. So here's where we really benefit from the Peruvian, sort of the audit of like the estimated recovery times here. So the left panel shows the data again in blue, and then the gray lines here are basically, let's take everybody's, diagnosis and let's replace it with the, average recovery time by age, sex, and occupation from the Peruvian data. And then on the right side, we can basically just take the proportional differences between the two and see that, yep, we've got some excess mass here maybe at, well, it looks like it's at 5. For sure, there's an excess mass at 11 if you're taking these other times as God's truth. So that's a really, that sort of illustrates the value of this data right there. And then, another really interesting feature here is that, there's a lot, some of you would be familiar, there's a big literature in workers' compensation about kind of time of day, day of the week effects. And so people value basically like long weekends. And so you can see here that if you're taking a 1-day spell, you wouldn't necessarily expect the advent of this spell to be, differential based on day of the week, but, you're much more likely to take a 1-day spell on a Friday. And then here you can see basically you're more likely to take a 2-day spell on a Thursday, a 3-day spell on a Wednesday, 4-day spell on a Tuesday, and a 5-day spell on a Wednesday. So when you aggregate across days of the week, you definitely see evidence that these are not just, people getting sick and going to their physician and getting their, kind of objective, like you must rest for this certain number of days. Okay, so I think a little bit in trouble in terms of time. So in terms of the workers' problem, the workers face stochastic health shocks. They're characterized by 2 things. The first is theta, which is the sort of objective number of days that the worker is sick here. And then we're gonna kind of put a cap on that, I think, for tractability. And then the day of the week that the worker falls sick, is something that also kind of influences the number of sick days that they take. And so we're gonna model that, as well. So once the worker is sick, you don't really have any more uncertainty here. You can basically like solve the worker's problem. And so the worker is going to choose how many days of time to take off of work, which we're going to call S, and it's just going to maximize that worker's utility over their consumption and leisure. So they're eating all their, earnings at any given time period. There's no kind of dynamics, here. And, they do get some value of their leisure time relative to work time that we want to kind of build in, as well. So the important things here are the, B of S is the average replacement rate for days missed. So that's the schedule that we're trying to find the optimal function for. And there's also this function F that captures the cost of filing the sick leave claim above your health shock. So this in the paper is motivated as the risk of getting caught violated your mandatory rest period. So apparently they will check and see if you're at home when you say that you're supposed to be home. So if you're at Six Flags, then you are really in trouble and you could get, fired. I think there's probably also an element of maybe a psychic cost of convincing the doctor to certify a higher number of days and how hard that is. That could be, kind of subsumed in here as well. And then Q is this utility boost of extending a weekend. So you just sort of get it kind of flips on and off. And then the worker's sickness affects, the production, like the size of the pie that we all split together, in two ways. So first, working while sick is less productive than working while healthy. So this is that presenteeism element that we talked about before. And then secondly, working while sick with a contagious disease can affect your coworkers' productivity, either directly or indirectly. So we're not going to model those two things separately here. We're just going to have one, factor nu, which is, less than 1 and apparently can go all the way to infinity. And it's going to represent the worker's reduced productivity working while sick. And it's also going to factor in these downstream effects. So this is something that's really hard to estimate. You'll see, if I don't blow it on time. Uh-oh, when did we start? Okay, we started late. We'll see that, we need to kind of take in an estimate from the literature, and that's what the McLean paper does as well. So in terms of thinking about, I'll go fast, sorry. I didn't plan my time well. Okay, so in terms of thinking about like future directions, figuring out this sort of contagious effect, I think actually has a lot of, upside potential in terms of, helping fit these models. And also, this is our new world, right? We're thinking about COVID. Okay, so the social planner is going to seek to maximize the worker's utility, which, now we build in this risk aversion component because the worker, does, like they do care about, their utility across states of the world. So this function G is basically going to be integrating over our utility, taking our optimal choices, for a given theta, over the distribution of all possible thetas and days of the week. So here we're taking G as given. So we're not modeling any sort of moral hazard into the risk of getting sick, given generosity of sickness pay. This is something that workers could potentially control, especially if they don't have any sick pay or very, stingy sick pay. And then for certain infectious diseases, you could think, I thought that the infectious disease component was going to come in here at G, and it didn't. All right, and then we're going to maximize that, kind of giving everybody weights. I think they are equal, subject to some constraints on the system. So to solve this problem, we need to restrict the class of possible functions. We're going to basically look at functions that look very similar to the Chilean system, but have maybe different replacement rates at different periods. And we're going to keep the 3-day period, but we're going to allow maybe the 11-day period to kind of move. But what do we need, right? Like we need the we need to understand like what the worker's utility function is. So we need estimates of these like phi's and f's and things like q's, these things like that. So what are we going to do? We're going to take, like people's actual experiences in Chile under their current, BS schedule. And we're going to, try to figure out what kind of Greek letter estimates kind of give us the best estimates of matching people's decisions that we observe. So here we're going to model this F function using, we're going to allow for quadratic penalties in the distance from, your real true sickness. And we're going to have specific costs of deviating 1, 2, or 3 days. So that's going to give us 4 parameters. And then the preference heterogeneity here is the kind of value of leisure and the kind of the penalty function for, convincing your physician or getting that certification. I need to kind of skip. Some of this is like obvious. Okay, so we do have some kind of additional things that like need to go into the model to just, make it look more like what we actually see, because we do see kind of heaping and rounding and things that you would observe in administrative data sets. And so in the end, we have 10 parameters that we're going to estimate. So we're going to estimate using simulated method of moments. And so what we're going to do here is basically, try to like find the Greek letters that match the moments as that come out of the model to the real data as closely as possible. So this, I gotta say, I have a hard time with these estimates of like what the different Greek letters are in these various models. So it is a very nice, showing of like what the different targets are that we're estimating and kind of trying to figure out like what are the moments that we want to use to match the model. One thing I like is this exercise where we look at, bunching around 11 days, which is not a matched moment in the model, and see how well, the estimated model kind of fits that, and it does a pretty good job. I'd like to see 3 days. So now we have estimates of all of these different, preference parameters. Now can we solve the social planner's problem? Well, we have to, go back to kind of our, class of B functions. We're going to impose some more, impositions on the B kind of space. We're going to use the estimates from the structural model. We can't identify risk aversion, so we're just going to take gamma, we're going to set it equal to 2, and then look at some kind of sensitivity around that. For production costs, we're going to use an estimate of the cost of presenteeism from a paper of mine where we basically use survey data and ask people, how much less productive were you when you worked while you were sick? So it's not great, but it's actually the best we've got. It's what the McLean paper uses as well. I'm not totally sure how this is solved. It doesn't seem solvable analytically, and I couldn't find the description in the paper. But I know you can solve this. I just would have liked the description. So here is the, if I have to get the hook now, like we've shown you basically the bottom line of the paper. So the blue is showing you the current Chilean system, and the red here is showing the optimal policy estimated, using these preference parameters and kind of assuming this functional model. And then you can see for reference, the dashed line gives you kind of just full replacement rate if there were literally no moral hazard concerns to worry about, and everybody, just like fell sick and took what they needed, exactly. So, so there's sort of some 3 key takeaways in terms of the optimal policy. The first is that it does offer a partial replacement for claims less than 4 days. So we get rid of this kind of waiting period, and we give them, we give people some kind of 30% replacement for those early spells. We eliminate the discontinuity at 11 days. If I had to guess that this was going to be something that happened, ex ante, like I would absolutely have won my money here. People like economists love discontinuities and people don't. And then it doesn't offer full replacement for claims longer than 11 days. So there is this, we are realizing that there is some sort of moral hazard effect where people kind of can stay sick forever, and maybe we can kind of nudge them back in. And then one other really nice feature is that with a structural model like this, you can estimate what, percent of earnings workers would be, willing to give up under the, to be insured under this optimal policy versus the policy that they have. And so the estimate here is 1.5% of their earnings, which I don't think is chump change. So in conclusion, this is a really nice paper. I love it. It addresses an important, I think, very understudied question, using really novel data and methods. So I see a lot of papers estimating structural models and then doing like a bunch of different counterfactual policy experiments. I love that. I think it's fantastic. But I really like that this paper takes it a step further and tries to find the optimal policy. I also really like the use of these objective assessments for recovery time. I'd like to know a little bit more about Peru's system just to make sure there isn't anything kind of weird going on there where like it's a feature of Peru that like the cold is going to take structurally longer or something like that. In thinking about how to structure sick pay, this has really gained new importance with COVID-19, right? So one thing you could do with a model like this is you could basically introduce, okay, I'm done. You introduce a new disease and basically kind of see how that, affects things. The trick here is that something like COVID it doesn't really necessarily like there's this heterogeneity, right? Like it can kind of wipe you out completely, or you can be asymptomatic and then give everybody else COVID. And that asymptomatic giving everybody else COVID component is missing in a model like this. I'd like to know about incorporating multiple spells, just thinking about cumulative sick days in a year, and then generally, like I started showing you that like half these big, high-income countries have this employer-sponsored, system, and half has social insurance. Like, should we all be doing social insurance programs? Would this sort of model be able to speak a little bit to that sort of design component as well? And you could estimate all those different, models and kind of see how they fare in this system as well. All right, that's it. I'm sorry I went over time. They got very excited about the paper. So thank you very much.
Okay,
Okay, hi everyone. Oh my God, thank you so much. That was a great discussion of the paper. Well, first time in a conference like this one, so I'm not exactly sure what I'm supposed to do. Let me, okay, yeah. Okay, can you just give her slides? I will just talk without slides. No, you don't have, like, this is, yeah, well, okay. You can share it, just in case, but I don't think that I will use it. Okay, so we'll be rather short and get more of your comments or questions. I think that I have some notes in like 3 or 4 key points that Kathleen brought up. So one thing is that she did an amazing job at motivating the paper, which is better than what I think that I do in the introduction. So this is super inspiring to the next iteration of the introduction. So thank you so much. I think that one of these, one really well taken point is I am leaving outside women utilization. So we think, yeah, I justified as lower participation in the labor market and they will need to model the extensive margin. I totally agree with you that I'm not like, I won't put all my money on that argument. This is a trade-off, right? How much you keep in one paper, how much you do in another paper. I think that for like incorporating women, I was trying to actually aim a little bit maybe more general in terms of thinking about household dynamics, and that something that will be important here is who is a primary earner versus a secondary earner in the household, and maybe who is picking up basically when their kids are sick will depend actually on this, who is a primary earner. So what I'm trying to do is to actually link this data with employment records in Chile to try to have the household composition, and that, so yeah, fingers crossed, I'm going to convince them to let me do that link. It's a little bit also the reason why I'm not incorporating women in this paper, but I think it will be super interesting. And I feel very bad the day that I dropped women out of the sample. If it were for me, I was going to just write the other paper, but well. I focus on 2017 for the estimation of the model. I think that I'm not sure if this is in this version of the paper. So I was trying to do this where you pick one year of your data, you estimate the model using that, and then you check the model fit using a year that you didn't fit the data for. So I've done that with the 2018 data, and estimates look very, like the model fits the data well in that sense, but that's not in the new version, but that's something that I'm going to incorporate. And okay, something that I thought a lot about, and this is a really well taken point, is when you incorporate these contagious effects, I am taking G as given. So what I'm trying to say here is workers can choose to go to work sick, and this will infect other workers. And the approach that I'm taking right now is that I am not updating the probabilities of getting sick based on this potential behavior of workers going to work sick. So I am like discussing with myself what to do in that case. On the one hand, one argument to support this approach is, look, the probabilities that I use, absent of COVID, okay, so the probabilities that I use from the data are in a way equilibrium probabilities. So people are going to work sick, yes, they are doing that behavior already. So when you look at the probabilities from the data, there is already picking up some sickness that you get at your office rather than on the street or on the bus. So in a way, these equilibrium probabilities are already getting at that. If you think of a traditional disease like the flu, if you try to incorporate something like COVID, I totally agree that then trying to understand the interaction between the behavior of workers and how they're affecting your probability of getting sick it becomes something that is much more relevant and that will actually change or have an effect on your estimates that I believe will be more salient. So I am like trying to maybe think harder about maybe how I justify the use of these equilibrium probabilities in a way and why there is no interaction with G for traditional diseases that are contagious and not COVID. I'm solving the contract for a restricted set of contracts. Point well taken. And that's something that I'm working on. So yeah, this is kind of like a restriction because if you allow the set of contracts to be any piece while linear function, it becomes a really huge set. I am trying to simplify that by saying, oh, let me look at how the Chilean contract looks like and follow this lead. But I really like your idea. I think that this is super helpful, where maybe I can use what other countries have done, which is very in like appendix table 11 or something like that. And you put a really nice table on this as well in your presentation. So maybe I can take what other countries have done and ask, well, let me look at the set of contracts that we see in reality. So some of them have only 3 days deductibles or like non-payable periods, and then you don't have 11-day kink. I think that that's the most salient thing from the Chilean system that I would like to remove and provide an estimation of how the policy will look like if you don't do that. So I will stop here. Yeah. Question. Can I take questions?
What's that?
I was ready. I didn't want to miss it.
He was going to go up before
So-
you were talking.
Two of our grade price students are going to help assist with the discussion. We'll have a couple mics moving around as best we can. Both of them will be on the market next year. We have Virat and Agrawal. Virat, 5 words or less, what are you working on?
Contemporary shocks to the healthcare system, COVID-19, high inflation, and health behavior.
Thank you. Drishti Bed, what are you working on?
Mergers and acquisitions in pharmaceutical markets.
Thank you. We're kind of figuring it out.
Okay.
Why don't you start yelling and we'll keep figuring.
Okay, I have a couple of questions. Some clarifying and some maybe not. So one thing. Oh, thank you. So one thing I was curious about is, I guess this contagion point. So to what degree is the contagion point going to be captured by the sort of productivity of other people costs, right? Because that's something you have. So so that could be, that maybe it might be a problem in that you're like, it's kind of biased in a way because it's picking up something that's not intended to, but it might also be a solution where you're like, this is kind of a catch-all for the costs I'm imposing on other people, which would include these sort of, these kind of contagion effects. I'll just ask you all my questions and then I'll stop talking. Could I?
Yeah, sure.
The clarifying question is, do you have like a disutility, I think you must, but like a disutility of working while sick?
Yeah.
Okay, fine. And then the third thing, and this is just a question about, how your model works, is why isn't like just 100% replacement rate day by day, like the optimal policy? Like what in the model is driving, right? You have like that weird replacement rate that they have, and then you have like just 100% 45-degree line, and then you have like your optimal policy. So I'm just curious, like what kind of in the model is driving that to be the solution?
Oh, I see. Okay.
Because it seems like an obvious thing would be like 45-degree line would be like great, right? So
But that's only absent of modern custom, right?
yeah, no, I'm not saying you're wrong. I'm just curious, like what in the model is sort of, I don't know,
Okay,
driving
okay,
it.
no, but, okay.
Okay.
So let me see. Maybe I can. Okay, I'm just going too fast here. Okay, so maybe I can use this here to get at your first question on what I'm doing between the contagious part and the effect on productivity. So far, what the model has is you get this health shock, right? This will make you less productive, and that will have 2 effects. One is on your own productivity. So if you show up to work sick on that day, you won't be able to give your 100%. If you show up to work sick and you have a contagious disease, that would mean that you will also impact your coworkers. I am bundling that in one parameter, which is this no parameter that is really hard to estimate. So I am relying on previous literature. You could think about trying to separate this, okay? That's something that and I think that this is your question. I do not separate that in this paper. You can try to model that in a different way. What I think that the next version of the paper will end up doing is the following. This version fits one estimate of no for all the diseases, okay? Which is like a really strong assumption. I'm assuming that even if you have a back pain or if you have a cold and you show up to work sick, that's your no comes from outside data and just one estimate. Yeah, that's a really strong assumption. You can think of having a no for non-contagious diseases and one new for contagious diseases. Then the new of non-contagious diseases will just be your productivity shock, period. And then with contagious diseases will be something like the productivity shock on yourself and potential productivities of other workers. So this extra like production externality. I think that should be something that I could implement within the structure of this model. And I'm trying to understand where this estimate of the specific nodes will come from. So this is one of the cases where maybe I can like write the model in a more general way, and then when I take it to the data, unfortunately, it will be reduced to maybe just 2 estimates of the node. Also, just to be super transparent here, the node also doesn't vary by occupation or by age, but that's something that I think that we can like flexible, do in a more flexible way. I do have a disability for working while you're sick. And the last point was about, sorry, I didn't take
Why do
performance.
you get the optimal policy being
Ah,
not
why I don't know
replacing?
how, yeah, that's how, so, even if under any possible, so you have some estimates on how workers behave, right? These estimates will imply that workers will not report, so maybe your question is a more general one. So workers will not, I am not deriving a contract
can
where
be more
workers are going
specific.
to report their really, like their true health, right? If you could make workers report their true health, I think that the solution will be the 45-degree line.
Right.
Okay, the estimates of the model suggest that workers do not report their true health. And what I'm after is kind of like a second best type of contract. So given these responses to different replacement rates,
Okay.
which contract should I provide to these workers?
Okay. I think it
Okay.
would be,
Does that make
I
sense?
mean, no, it does. I think it would be,
Okay, so I hate to cut this off, so I have a bunch of questions for you too, but
Okay.
I'll have to annoy you during lunchtime or
Yeah,
something.
that's perfect. Yeah.
So I hate to cut off a great discussion, but we want to give Emily a chance to present Shengmao's paper. So
Hey, there you
But
are.
I'm happy to talk about all
Welcome.
this.
Infectious disease.
so
You'd have to have a super infectious disease for it to make sense to encourage people to stay home. And if
okay,
you have
okay,
the
yeah.
asymmetric
Yeah, that-
information as well,
Yeah.
like you can solve that, but.
Yeah, thank you. Yeah.
let's give Kathleen and Vicky both.